were also talking about height being the main parameter. I'd like to talk about obesity. So I think, and this might be sound layman to you, but I think in obesity we also have to consider that there's a chance of pulmonary hypertension. So how do you then control the tidal volume considering?
Sure. See, the pulmonary hypertension part is generally something we're not considering on a day-to-day basis when we're ventilating obese patients, but we are considering another factor called the PEEP. So PEEP is positive end expiratory pressure. So you assume you're blowing a balloon. So as you blow the balloon, it kind of expands, but then if you don't keep blowing air in it or tie it off, it's going to deflate. So PEEP is positive end expiratory pressure, which is the pressure to keep the thing expanded, the balloon expanded. Likewise, to keep the lung expanded, you need the PEEP. So in obese patients, you may need to use a little higher PEEP to kind of keep the lung expanded because of the increased intrathoracic pressure, because of the raised diaphragm. Right.
Okay. Since we've talked about NIV and the parameters that you have to consider when putting people on NIV, can we also talk about weaning people off ventilators? So I think that's also a very important thing to understand exactly when is the correct time.
Sure. So in the COVID pandemic, many people didn't come off ventilators, unfortunately. They kind of died because the respiratory failure, the ARDS got so much worse that it just didn't work. But when you're weaning somebody, the concept people talk about now is liberation from mechanical ventilation. They're not even talking about weaning, they're saying let's just get the tube out when they're ready. And the big concept there is to make sure that the patient is ready. Because you can keep tweaking the device support depending on how ready the patient is, and there you need to do something called the spontaneous breathing trial and the spontaneous awakening trial. So every day you need to check them off sedation to see are they awake enough, alert enough to breathe on their own. You also want to do a breathing trial where the machine is giving very minimal support, a little bit of PEEP, a little bit of pressure support they call it, so you can actually see if the patient can breathe on their own that way. There's also a number which we use called the rapid shallow breathing index, or the RSBI, or the F by VT, or the frequency by tidal volume, and that number is a number which suggests whether this patient will successfully come off weaning or not, and the cutoff there is about 105 or so, the F by VT. So if you take the F by VT, and the course actually has some details on this, by the way. So if you have a frequency, the patient's actually breathing fast, say at 25 times a minute, and the tidal volume generated only, say in liters, is 0.5, which is 0.5 liters, 500 ml. So 25 by 0.5, the F by VT is 50. But assume that the patient is breathing at 25, but the tidal volume is only, say, 200 ml, so 0.2. Then you end up with the RSBI being much higher, more than 105. So your chance of weaning is less. You also want to make sure that they're metabolically okay. For example, their phosphorus should not be too low, because that has something to do with the muscle power. You also want to make sure they're not having metabolic alkalosis. You also want to make sure they're not over sedated, because then you take them off the ventilator and the sedation kicks in, that's going to be a problem. So there's a few things you look at. You also want to look at how long is it going to take them to wean. It's somebody with, say, neuromuscular disease, say somebody with like myasthenia gravis, or someone who had a cervical spine injury. The duration of ventilation may be much longer. So your weaning process may take longer till they regain their muscle strength back. Some people don't get it, and sometimes then you end up with home ventilators for years together. So it's kind of important to recognize and guesstimate how long a patient is going to be on a ventilator, because it also depends on your resources for the ICU, because you're going to be blocking off an ICU bed for this patient, and it's helpful to understand, okay, this is somebody who's going to be on the ventilator for a long time, and then you have to think about what are the things I can do to prevent infection, what are the things I can do to minimize their lung damage, and when do I shift them from endotracheal tube to a tracheostomy? Should I do it early? Should I wait? So these concepts are also kind of coming up, and there's some very good guidelines out there now which actually say that there's no great difference between early and late tracheostomies, in fact, but in general I would say that about 5 to 7 days or so, if they're still stuck on the ventilator, may be worth considering a tracheostomy. And this is an area we didn't talk about. There's a whole concept of palliative care, where sometimes people should not be put on ventilators, right? Somebody who has a chance of not surviving, somebody who's having so many medical issues and they don't want to be on a ventilator. We need to talk about the palliative care options, where you can actually take care of them quite effectively without being on a ventilator. Because ultimately, why do you put them on a ventilator? Because they're short of breath and they're dyspneic. But some people who wouldn't do well on a ventilator, you can still relieve their dyspnea with medications. You can adjust their medical causes of their illness and try to control that. Somebody in heart failure, you can kind of get the fluid down. So there's other ways to look at supporting somebody's feeling of shortness of breath.
Okay.